Well, hello, everyone. My name is Dr. Jim Borchers. I'm the president and co-founder of the U.S. Council for Athletes' Health. And as you know, we've been very involved in thinking about how to prioritize athlete health, safety, and well-being in all levels of athletics, but in specifically college athletics, where we've spent a lot of our time. As you know, we were very fortunate this past December to have Dr. Brian Hainline join us as a senior advisor here at the U.S. Council for Athletes' Health. As you know, Dr. Hainline has been most recently the immediate past chief medical officer for the NCAA. Dr. Hainline was the first chief medical officer for the NCAA and really was the architect of many of the best practices, standards that have come out in the last decade plus around best practices for health, safety, and well-being for collegiate athletes, but also for athlete healthcare in general. Dr. Hainline is also the immediate past president of the U.S. Tennis Association and is known nationally and internationally for his excellent work, not only in the physical health and safety and well-being of athletes, but in the mental health and emotional well-being of athletes, holistic care of athletes, and I think is widely recognized in the world as a leading expert. So Dr. Hainline's joining us today for this conversation. Brian, good afternoon, and great to see you here today.
Well, great to be here with you, Jim, and thanks for those kind words. And looking forward to having a nice chat.
Yeah, this should be a great conversation. Brian, the first area that we wanted to talk about today, I know, was a little bit about the historical review of some of the best practices and standards that you were so readily involved in, and especially has been put together by the NCAA. And as a bit of historical background, certainly when you came on to the NCAA and the Sport Science Institute was developed and created. Many people at that time were focused on concussion, but there's certainly been significant other work that's come out of the time when you were at the NCAA. But could you maybe just spend just a little bit of time talking about the history of the development of those best practices and why it was important for the NCAA, yourself, and the Sports Science Institute to develop best practices and standards that have become requirements in college athletics?
Oh, sure, Jim. So when I came on board in January 2013, the primary Bible, if you will, coming from the NCAA was the Sports Medicine Handbook. And the Sports Medicine Handbook was primarily put together by members of the Committee on Competitive Safeguards and Medical Aspects of Sports. And so we have to get back to the Constitution of the NCAA. Constitutionally, they are the committee, the volunteer membership committee, that's empowered to oversee health and safety. So it made sense that they were doing the Sports Medicine Handbook in conjunction with what was then called the Health and Safety Unit of the NCAA. It was a tricky document. I think it was pretty good, really. I mean, the athletic trainers and the physicians used it widely. But from a medical legal point of view, and from the point of view of being authoritative, it kind of fell through the cracks. And I think it put the NCAA in a tricky position from the point of view of setting community standards. So we went about a different way. We said, how can we best change the culture of health and safety? Well, how you do that is by shifting the community standards. And what we started to do was to have task forces and summits where we invited the core members of the membership, so from Division 1, 2, and 3, always the student athletes, coaches, presidents, athletics, healthcare administrators, and then we would bring content experts, and then we would have NCAA staff. And I remember the first best practices we put out, and it was on mental health. So it was the NCAA mental health best practices. How that came about was actually my first week on the job. I met with the leadership for D1, D2, and D3 from the student athlete advisory committees. And they looked at me and said, Dr. Hainline, we get concussion. Can you please make mental health your priority? So we put together a group, and ultimately that best practices was endorsed by 25 organizations, 25 of the leading mental health scientific organizations in the country. And it was really embraced by the NCAA membership. But interestingly, And some people, were a little skittish about this. We bypass legislation. We bypass policy. So legislation means that the NCAA membership votes on something. Policy can be set by the Board of Governors, which is the highest governing committee of the NCAA. But we created a best practices document. Then we went ahead and did that for concussion. We did that for independent medical care. We did it for preventing catastrophic injury and death. We did it for cardiac care. So it really became a trend, and the membership really seemed to warm up to that. And it was really including the entire membership, not just one committee. But the other shift that happened was that these best practices then started to become bylaws. So there was a bylaw passed that said that every member school must have in place policies and procedures consistent with the NCAA concussion best practices. Same thing for mental health, same thing for independent medical care. So it really was a nice journey, I think a very inclusive journey. And I think what was most gratifying for me was the outside scientific and medical organizations. They really stepped up to the plate, using a sport metaphor, and really they saw that by creating these standards, we weren't just doing something good for collegiate sport, we were doing something good for sport. Because importantly, I was the first full-time chief medical officer of any professional or amateur governing body in the United States. So the NCAA really took the lead, and then I took that responsibility and said, well, let's build an incredible collaborative network. And so that's kind of a synopsis of how it happened.
No, it's really great historical synopsis, and I think sets the foundation, Brian, for my next question, which is in society in general, the amount of consensus you were able to build from these organizations around sports medicine or mental health, around these best practice documents, around the recommendations that have now become requirements for NCAA institutions, has really solidified, I think, in the communities, as you mentioned, or in sport in general, their significance. Can you talk a little bit about that, maybe, extra benefit of having that sort of support in actually what it does for these documents, these recommendations that came out in these best practice documents?
Yeah, well, it gets to something unique, peculiar, maybe sad about the United States. So in the United States, we do not have a minister of sport. There's no central overseer of sport. One could argue for amateur sport, it's the U.S. Olympic and Paralympic Committee, but there are 50 national governing bodies of various abilities and financial wherewithal. And the USOPC just can't oversee all of that. And from a health and safety standards point of view, there is no central entity in the United States. Even if we take a sidestep, another great sport term, that for coaching, we're one of the few countries in the world where to be a coach, all you have to do is announce that you're a coach. You don't have to have any standards, any certification. So there was a gaping need, and for someone to step up and set the standards. And so the NCAA, I think, being the first organization to have a full-time chief medical officer, and then this collaborative spirit, but also sort of the desperation of, geez, can we finally get something done like this and set these standards? So the environment was almost perfect for allowing that to happen. So that was the biggest thing, I believe. And then what happened is we started working collaboratively with other organizations. So with the National Federation for high school sports, and then very much with the NFL, Major League Baseball, NBA. We all started collaborating and saying, look, we have these standards, and let's sort of make them more particular to professional sports. But that was the foundation. And I think the last point, which is important, is I was approached by the International Olympic Committee to co-chair their first ever summit on mental health in elite athletes. And that was because of what we had put together for our own NCAA mental health best practices. And the ILC said, look, this is such an incredible standard with endorsement by 25 organizations. let's use this and develop worldwide standards. So yeah, just the atmosphere, the tone, the mood, everything was just right for that sort of collaborative network to build like that.
It's really an incredible foundation. And I think one of the things that many in college athletics have struggled to understand is that with all the great work that's put out by the NCAA, it's really to the institutions to implement and police. But why doesn't the NCAA have an enforcement arm around this policy, so to speak? You mentioned some of the collaborations, but many of the questions come around enforcement, and we know that enforcement is a tricky word. It has all sorts of meanings and certainly all sorts of responsibilities with it. But maybe your perspective on the ideas around enforcement of standards.
Yeah, look, it's a great question, and I dealt with this and suffered with it very often as chief medical officer. So I think we have the NCAA has some of the best standards for health and safety of student athletes, really recognizing that they are the sacred asset in sport. And we have acknowledged, we meaning the NCAA, still wearing my old hat there, that all of the healthcare must be delivered by the campus. It can't be overseen by the NCAA. And there's a couple reasons for that. The first and probably most important one is because it's just impossible. You can't have Brian Hainline, chief medical officer, or Dina Casera, current chief medical officer, overseeing care at 1,100 schools and 500,000 student athletes. And then, the other thing that's interesting is where the health and safety bylaws are in the NCAA Constitution. It's in a part of the Constitution that normally is not enforced. So it's a nuance, but it's real. But I think from another point of view, once you start saying we're going to enforce, we meaning the NCAA national office or some special committee is going to start enforcing the standards, it means that you're going to be going to a campus, trying to understand what's going on, and then giving a penalty potentially for a health and safety violation. And that's just exceptionally difficult. In your medical practice and when I was practicing medicine, we didn't have a central entity that was coming, like the American Academy of Neurology or AMSSM or say Medicare that was overlooking how we were delivering care in our practice. That would have been impossible, and it would have been a tremendous imposition. Same thing for the NCAA. It just doesn't make sense. And so you get to another crucial point from a legal point of view. Once you set up enforcement of health and safety, you're getting into a legal quagmire, because then you're saying that the NCAA central office or national office or their designee is overseeing healthcare and health and safety standards. So it just didn't make sense. And it actually kind of brings me back to when you and I first met, Jim, in 2017, and you had this idea of setting up the U.S. Council for Athletes Health. And it was like a light went on in my head, and I said, this potentially could be the answer, because the NCAA cannot do that and should not be doing that.
Ryan, when you talk a little bit about these, to finish up on the standards themselves and the requirements and what's expected, I think one of the things in medicine that's very clear is that standards of care need to be followed and best practices need to be followed. And although they may not be enforced, they're certainly there, and we all have to understand them and have a requirement towards them. Sometimes I think there is a misconception that the standards from the NCAA only apply to Division I institutions, or maybe only apply to Power IV institutions. But is the intent that the association is providing guidance so that all institutions at all levels as part of the association would be part of engaging in the practice of providing the environments and following the recommendations for student athlete health and safety?
Yeah, no, that's absolutely correct. And whenever we held summits, task forces, and the like to create these best practices, D3, D2, D1, they were all equally involved. We weren't looking at D1 and saying, oh, let's create this standard because you have the money or the financial reserves to be able to do this. In fact, one of the things we made clear in all of the documents is that these are basically resource independent. So if you're an NCAA member school at any level, if you can't set up the basic standard of care for mental health, for concussion, for preventing catastrophic injury, maybe you're not really in a good position to be calling yourself an NCAA member school and hosting competition and championships and the like. So it's very clear that this was for all 1,100 plus NCAA member schools and not leaning toward one or the other. I think what has happened historically is that some of the more well-resourced Division I schools, they've taken those standards as a foundation, and they didn't just stop with the standards, they actually built upon them and made it something different. But, that wasn't our intent. That really is an option that's there. But the intent was absolutely black and white, that this standard of care, this community care, is for all NCAA member schools.
And so is it fair to say, Brian, that in your opinion, it's really the institutions themselves that have the responsibility to quote unquote enforce these standards at their own local level? I mean, I think that's where the enforcement comes, because lack of doing so certainly leaves institutions exposed to what might be expected.
Yeah, I think you can answer that in a couple of ways. So many of you may know, or if you don't, I'll tell you, I've spent many, many hundreds of hours working with our legal defense team, because just in concussion alone, when I arrived, we had over 600 concussion lawsuits, but there are multiple lawsuits for health and safety. And one of the core legal strategies was that the NCAA national office cannot possibly be responsible for what's happening at a campus. So legally, it's in the Constitution, and really it has worked out that way in terms of the defense of many, many of the lawsuits against the NCAA, that the core responsibility rests at the member school level. And it's even written, as I mentioned before, in the NCAA Constitution, that every school must have, a head physician, must have athletic trainers, and they must be in a position to deliver healthcare in a way that is safe and efficacious. And with that in mind, when you think about what really a school should be doing, I mean, it's not just, well, let's play defensive first, because you don't want to be sued, right? So just from a defensive point of view, there are two things that happen when there's sort of a catastrophe or a problem or an injury that just doesn't make sense. When a plaintiff's lawyer comes in, they look at, was there negligence? So was the athletic trainer negligent, or was the physician negligent? And those sorts of things you can't always protect against. And sometimes even the best physicians or other clinicians can make a mistake. But what really gets schools in trouble is the second tactic that plaintiffs' lawyers use. They look to see if the system is set up. So within the Department of Athletics and the school itself, is there a systematic approach to ensuring, as best one can ensure, that the student athletes are protected from a health and safety point of view? And that really means, is there a system set up so that all of the best practices, all of the policies, all of the bylaws that address health and safety, that school has been proactively putting in place policies, procedures, education to enact them? That is really, really critical to understand. And that really, maybe leaping ahead a little bit to another question, that ultimately falls under the oversight of the athletics healthcare administrator. I remember when the independent medical care legislation was passed, and I went on record saying, this is the single most important piece of legislation in the history of the NCAA. A lot of people told me I was exaggerating, but I don't think I was, because it says two things. One is that the primary athletics healthcare providers, which are defined in parentheses as the team physicians and the athletic trainers, that they have unchallengeable autonomous authority for all medical decision-making and return to play. So it's not the coach, it's not the administrator, it's not an agent, it's not, an NIL operative or anything like that. The other part of that legislation is that every school must have an athletics healthcare administrator who is overseeing the health and safety. And that part of the legislation sort of fell through the cracks. unfortunately, and it really must not fall through the cracks, because that person really is the enforcement arm, if you will, of health and safety standards. And quite frankly, that person needs all the help that they can get, so that there's a systematic approach to not only proactively taking care of the athletes, but also from a defense point of view, making certain that you're in a good position.
So, Brian, from your perspective, then, as the individual who really crafted that legislation around independent medical care, which really has, you know, certainly gone way beyond college athletics and has extended to many other areas of athletics. When we think about the role of a primary athletics healthcare provider and their ability to have the autonomous, unchallengeable authority to make those decisions, I think that was something that was very, very quickly recognized, digested. But it's this second piece around the athletics healthcare administrator that you mentioned is something that, as you kind of said, fell through the cracks. But those individuals oftentimes on campus were just kind of given this designation, check these boxes, sign these forms. But that's really not the intention, right? I mean, that's really not what that was meant to be. The role from your perspective, and from the NCAA's perspective in creating that designation, can you just expand a little bit on your thoughts around what the responsibilities from that individual are intended to be, from the NCAA?
Yeah, well, I'll tell you historically what happened, and it's probably no surprise. And because we collected data on who the athletics healthcare administrators were, and it was about 75% athletic trainers. And then we spoke to those athletic trainers, and it was something that just too often has happened, is that, oh, we have to have an athletics healthcare administrator. Well, give it to the trainer. They don't even call the individual by the right professional name. And that athletic trainer all of a sudden had that responsibility, but didn't have any administrative time carved out for it, didn't have a pay raise. So he or she was just expected to continue to do all the duties and to do that by the way. And I spoke about this endlessly and said that is not the intent. That's not the way it should go. And sometimes I used an analogy, of my practice. I had a very large practice before I came to the NCAA, and I sometimes use this simple analogy: my office manager, and my office manager, she would come to me and say, Brian, it's probably not a good idea. In fact, it's a very bad idea that you left your prescription pad in the patient waiting room, or that, this chart is open, or that, all sorts of things that I needed to follow, not only to have an efficient office, but to make certain that I was carrying out all of the standards of care that I was supposed to. She wasn't telling me, Brian, this is the proper dose for your Parkinson's patient. You have to change the ratio of carbidopa, levodopa, stuff like that. I mean, that was not the intent. We never wanted the athletics healthcare administrator to be overseeing medical care per se, like this is how you treat a concussion, but to oversee the standards that are in place and to make certain that everyone is following those. So it really takes a rather sophisticated individual who doesn't have to be a certified clinician, but has to be in a position to really run a very busy practice, if you will, and make certain that everything is going right. So I actually thought that the position probably should not be an athletic trainer unless you took that athletic trainer and removed him or her from all their clinical duties, and they were set aside just to do this. And that's unfortunately now what happened. But we're seeing now that that's starting to happen in D1 with what's called the D1 holistic model.
Yeah, can you expand on that model? Certainly, the transformation committee and some of the things that happened towards the end of your tenure at the NCAA began to try to reinforce the importance of the position of athletics healthcare administrator. And certainly at D1 has called for more involvement and support. But can you talk a little bit about some of the emphasis there that helps to enhance what this position may accomplish on campus?
Sure, and also some history there. So when the transformation committee was meeting, and sometimes when committees can meet and they're almost like get in a silo, and they were trying to almost reinvent, well, what should we call important from a health and safety point of view? And um, and I sort of knew this was going on, and kept trying to butt into their party, and say, look, I don't think you need to do this. And finally was able to speak with them and say, you have everything in place. You want to do mental health well, follow the NCAA mental health best practices. You can't get better than that. You want concussion management? Well, we have a concussion safety protocol checklist. It's the foundation of what you need to do. So walk through all of those things and said, what you really need, and which is not being emphasized, is to empower. And I really stress that word, empower the athletics healthcare administrator. If that is done, and you're really doing it in such a way that it's a unique position, you're giving that person what they need, and everyone in athletics understands that they are the overseer of making certain that the standards are in place. If you do that, that's probably 90% of what you need from a D1 holistic model point of view.
Yeah, it's really interesting because one of the things that we hear is that, as you mentioned, sometimes people are put into those positions. It's not a known skill set, athletic healthcare administration. I think, as you mentioned, that sometimes gets mistaken for the clinical care of the athlete. We have some amazing clinicians, obviously, and people that provide clinical care for athletes, but this whole administrative piece is a different piece. One of the things that came out of the transformation committee was the need for, an organization or community. I think that all of us in any sort of healthcare certainly, enjoy when we can get together with others and learn and exchange ideas. And as you know, in full transparency, at the U.S. Council here, we have an athletics healthcare administrative group that has over 1,000 members, and we talk about non-clinical issues that are important. But just in general, the idea of that community, why is that important for athletic healthcare administrators?
Well, I remember discussing this with Donald Remy over 5 years ago. So Donald was the COO and the chief legal officer for the NCAA, and I said, look, this position is so important. And once you develop a community, and really it's no different than the community of athletic directors with NACDA, or the community of faculty athletic representatives with FARA and so forth, is that this community really does a few things. One is it's a sounding board. You learn from one another, and it also gives a certain legitimacy to this whole concept of having an athletics healthcare administrator. So I just think having a singular organization or association where they can learn from one another, share best practices, and really sort of have a cohesive whole. And then that in and of itself organically helps really push other standards in place, because then you get everyone talking to one another. So I believe very strongly in that, push for that. And actually, even 5 years ago, I remember with Donald Remy, I said, I think USCA should really be that umbrella, because they're involved more than any other organization, and they could really cohesively bring everyone together. So when I was wearing my chief medical officer hat, I was hoping that was going to happen.
Yeah, I know that's always been something you've advocated for, and certainly something that was important to you. Can you talk a little bit about the role of an athletic healthcare administrator? Maybe share from your perspective, for example, their role in providing the education that's required from some of the best practices, or their role in making certain that things like exercises, punishment doesn't happen. How do you see that role on campus from your standpoint? We talk about appropriate acclimatization and transition periods, all these things that are called out for in documents, especially I think in preventing catastrophic injury and death, which obviously always grabs the headlines. What should the role of an athletics healthcare administrator be?
Well, I'll take another step back before answering that. You can have the best athletics healthcare administrator in the world. But if that individual is not empowered immediately by the director of athletics and ultimately by the president of the university, it's a worthless position. Because then, he or she will be saying this or that. If the coaches don't want to listen, they don't have time for that. They think it's a waste of time. The athletic director is thinking more about fundraising and trying to work out all the NIL stuff. It's going to get buried. So the first thing, and those were the words that we use very, very carefully with D1 Transformation Committee. It's empower the athletics healthcare administrator. So once that person is empowered, what it really means is that you're working collectively with the coaches, but you're also working individually with all of the teams. And so you have to set up a system in place so that that at the beginning of the season, mid-season, multiple times of the season, that all of the core things that need to be discussed are being discussed. It's not enough. Well, this is actually an interesting study that was done. It was an Ivy League hockey team, and they had all been given a concussion education sheet to sign off on, when they first started the year, along with about 1,000 other sheets. And this was actually published. A year later, not one of them remembered having done that. So it's not enough just to say we did that, check it off. There really needs to be sort of there has to be a comprehensive assessment, a checklist, if you will, but it means that everything needs to be rehearsed. So, I know we've been on the field, and speaking of catastrophic injury, so what's one example of rehearsal? You have a football game, you have to have rehearsed how you're going to manage someone with a suspected cervical spine fracture. Same thing in gymnastics, same thing in track and field, where it's not enough just to have checked off that box, but how to do it. For a mental health emergency action plan, it's not enough to check that off. It has to be rehearsed. So I think the athletics healthcare administrator is making certain that there is aptitude that's developed. So ineptitude means you have the knowledge or you check something off, but you don't know how to deliver it. Aptitude is the opposite of that. It's knowledge-based in part, but it's practice-based as well, like a fire drill. So that person really is overseeing comprehensively education and being certain that people understand the education, that there's time put aside for that education. And it's even amongst student athletes, that there's a buddy system set up so that they know how to recognize certain things with one another. And we've seen that in concussion. It's been highly effective that student athletes now are actually calling out other student athletes that may have had a concussion, and they're saying, hey, you got to step out, because not only is this not safe for you, but it's not good for the team if you're playing concussed. So it's all of those things, but I think the rehearsal, that concept of rehearsal, both globally, but at a team level is critically important.
The other thing, Brian, for athletic healthcare administration that we've talked about in the past is consistency and alignment, making certain that, there aren't unintended gaps created by individuals kind of recreating the wheel, so to speak. And certainly there's a lot of value in that in healthcare in general. We know in other healthcare situations, conferences have been asked now to become part and parcel to some of this process, just as we see faculty athletic reps in conferences, bringing athletic healthcare administrators together. But can you speak a little bit to the importance of understanding your peers and their resources and trying to make certain that you're consistently applying some of the best practices and standards similar to your peer group?
Yeah, that's where it gets tricky. So, the NCAA does give surveys to D1 and D2, and so if you look at those surveys, you can kind of compare where you are as a school to what other schools are doing. And that's fine on the one hand, but let's say you have a knowledge gap that you haven't really set up the standard of care for a mental health emergency action plan. Just knowing that alone is not enough. So it's also, how do you get guidance for those sorts of things? So I think once you empower someone, you also have to be certain that that individual is aware of what's happening, generally speaking, in other NCAA member schools. And, if they can be given guidance on, are they doing a good job or not? And so that's another potential gap. So the NCAA Sports Science Institute really is helping to set the standards with the other organizations, scientific and medical, and certainly with CSMAS, the Committee on Competitive Safeguards. But they can't then go in and say, well, look, maybe you should be thinking about it this way, or maybe thinking about it that way. So that's, well, look, I'm again leaping ahead, but it's a primary reason why I was excited to join USCA, because I think USCA, when we really look at this country, it's the only independent organization out there that is capable of assessing, providing guidance, and even going so far as perhaps accrediting or certifying a school. I think that's a future step, perhaps. But it can be a lonely place when you're all of a sudden put in there and you're responsible for all of those standards. And so I think having sort of an outside balance or an outside check is also very, very important and advantageous.
Yeah, we've seen that in other areas of healthcare where self-study is involved and getting some outside, evaluation of that self-study and helping you see that can be really important. I wanted to spend a few minutes, Brian, talking about an article that was released last week. Not so much about the substance of the article, but in the New York Times, there was an article that reflected on issues around the independent medical care, medical decision making, undue influence, perhaps from coaches or other outside entities, and the impact that can have on the athlete, but also the impact it can have on the providers. Um, it's certainly an issue. It's certainly something that is talked about quite a bit. That article brought out a number of things, including many of the best practices and standards that you worked so hard to develop for the NCAA. But the challenge for healthcare providers today and the need to be able to make some of those decisions and recommendations without feeling like, there's a outside entity that can have influence there. Can you just share your thoughts around that idea? And I know that it was certainly part of the impetus for independent medical care best practices.
Yeah, so that was a nice article. I believe it was Billy Witz from the New York Times, and he's always been a strong ethical voice, and it was one of many people who had my cell phone number when I was chief medical officer. Actually, same cell phone number, so he has it now as well. Um, but it brings up a couple of points. So a physician being fired, and maybe being fired because he was too independent thinking, because he wasn't going along with what the coach was saying, or and so there wasn't that true independence. At least that's what the essence of the lawsuit was about. There was a perception and maybe a reality that there wasn't a true independence. And when we were when I was working with the NCAA, and we would be presenting things to Congress, for example, and we wanted to get some congressional protection, antitrust protection, and it always came back to health and safety. And we would be able to argue from an NCAA point of view, look, we have set some of the best standards of care in the world. But they always said the same thing, and you can say it today, but there's no teeth to it. There's no ability to really enforce it. So let's say that a coach, through his or her influence, does make certain that an athletic trainer or a physician is fired. Well, there's an NCAA hotline now. You can report that, but does it really then work its way through enforcement? Well, not really. So again, there's this lack of teeth, if you will, lack of ability to really be certain that things are happening, and so. And I think it's very difficult for the NCAA to be in a position to do that. There's just not, again, constitutionally how things are set up. The enforcement staff, that's not their area of specialty. At one time, there was thought that we should put health and safety enforcement under the SSI. And they brought back that to me, and I said, well, yeah, I'd be happy to, for two conditions. One is it means I get to hire 500 people. And two, it means that somehow we're understanding what the legal implications of this are. So that went nowhere very fast. And of course, I didn't want to do that either. So again, it brings to light the need for some sort of an outside entity to be in that position, and it really to actually evaluate and to say, look, the standards are not being met. But even that's not enough. It also is the NCAA saying, yes, this outside entity is capable of whatever you want to call it, giving an audit that must be passed. Otherwise, the school can't be in championships. That's one example. Or if you move to an accreditation or certification level. So none of that is in place right now. But again, I think that really is the ideal solution.
Yeah, it's a really interesting issue when you talk about that. But there is another part of the teeth that you speak about, and what we see and is mentioned there is that unfortunately, when these standards or best practices aren't adhered to, there's another world that this lives in, and it's the legal world. It's the world where there is teeth, so to speak, and certainly that teeth can come in the way of monetary awards. It can come in the way of, other issues. But can you talk a little bit about now the environment as we know it from, the legal risk for noncompliance? Because I think although there is no enforcement or teeth, as you say, there really is. There really is if something happens. There is significant enforcement, and the documents, as I know, as someone who's been involved in being asked to be an expert and look at things, the documents that are produced are the documents you're speaking about today, the best practices, the standards that were developed, and they almost go line by line of asking, show us where you have annually trained your individuals in a way on these various topics. Show us where your emergency action plans are that are venue and topic specific. Show us a documented rehearsal of those emergency action plans. Show us your plan for making certain that there is appropriate transitions during times when someone's been off from sport to re-engaging in sport. And as you listen to these things, you realize that the enforcement is coming, unfortunately, after an event, but really makes an impact.
Yeah, and so I've been through a lot of those depositions and court cases where those questions were asked to me. By the way, I'll just tell you the strategy I always use when you're getting pounded with one question after another and you realize there's not a thing you can say. You just imagine that, it's a 3 out of 5 set tennis match. And you're only in at the end of the first set, you're getting pounded, but there's, still a lot of opportunity to come back. So with all those questions you were asking, Jim, I was being asked those same questions. And ultimately, the NCAA, their strategy was to say, well, this can't be the NCAA's responsibility. It is the member school's responsibility. It's an impossible situation otherwise. And really the courts have agreed with that. So given that with all of the questions you're asking, again, just to reinforce what we had discussed earlier, there are always two things when there's a lawsuit. And the lawsuit doesn't necessarily mean that a health and safety standard led to an adverse outcome of a student athlete. A lawsuit can be that you fired someone, and in doing so, you didn't follow the NCAA bylaws. So again, plaintiff's lawyers will look for two things. Was there an individual who was negligent? But it almost always comes down to, was the system negligent, or was the system not wired in the right way? So all of those questions that you are asking, every school with all of the great stuff that Sports Science Institute with CSMAS has put together, they are obligated to follow that. They have to figure out how to get that done. And if there's an adverse outcome, and adverse outcomes happen a lot, then the lawsuit is going to be set up pretty easily against the school because they don't have a system in place to have made certain that the education was valid, that there was adequate rehearsal, and that there was adequate screening, and all of the things that are so important in health and safety.
Ryan, one of the issues around the to tie some of this together around the Division One holistic approach now from the Transformation Committee is new attestation from the Athletics Healthcare Administrator, the athletic director, and the president, similar to strategies I think that the NCAA has used in the past to get an acknowledgement that these things are being done. So a signature there. Can you talk about that strategy and its effect on what a member institution is doing when they sign that attestation?
Yeah, so attestations are about as tough as you can get in health and safety, right? And we use attestations for sexual violence prevention and so on. So it gets you thinking about it. And when you think about the three signatures on there, the athletics healthcare administrator, the athletic director, the president, the most important signature from a practical point of view to be certain that things have really been looked at properly is the athletics healthcare administrator. Obviously, the most important signature from a legal point of view is that the president's signing off on it. And so a lot of times with attestations, there's an assumption. You know you have to get it done. And so you ask the athletics healthcare administrator, well, is everything in place? And then they'll say, well, yes, it's in place. And people just, and when you look at the history of attestations and when most of them arrive, they always, I'd say 90% of them arrive within a week of the deadline. So that tells you something too. It means, oh, we have this to do. It's not like in 1 week you can get all that figured out. So the attestation is the necessary part, but it's insufficient. And that's a great phrase, necessary but insufficient. And so if you really are taking the attestation seriously, it means that you have developed a culture, and it truly is a culture where all of these things are completely interwoven into every aspect of athletics. And that's radically different than signing off on a form.
So let's spend just a few minutes, and I know we've been talking for a long time here, and the information here has been fantastic. Let's spend a few minutes talking a little bit about approaches and solutions, because talking about all this for an athletics healthcare administrator, an institution, a conference, is really important. But what about an approach? What if you were going to recommend an approach for someone who's saying, okay, I understand that I have to get my hands around this, and I understand that there may be a lot of things that maybe we need to work on. I understand that this could seem overwhelming at first if I go through a checklist of 96 elements that I think I need to. What sort of approach or what types of strategies would you recommend that institutions or athletic healthcare administrators utilize to think about the best way to begin to be proactive and be successful in this type of endeavor?
Yeah, so there's two ways to answer that, and I'm going to be really sort of flippant or sarcastic in my first answer, because it actually was stated to me when I was in a meeting with a large number of D3 presidents, and they said, "Look, we just can't possibly follow all these health and care and safety standards, so we're just buying and purchasing a lot more insurance and to cover ourselves." And I said, "Look." And this is a true story. So look, if that's what the NCAA membership is telling me, that they don't want to really try to implement the best practices that have been developed, not by Brian Hainline, but by really a very large community of experts and the membership, that they don't want to follow that, but just buy more liability coverage, then I accept that, and I resign effective immediately, and I walked out of the room. So, it was to make a point, but I really was serious. So that's one approach, right? But I don't recommend that approach at all. The other approach, and it may sound like I'm just saying this now that I'm an advisor to AHCA, but again, going back to our history, Jim, when we met around 2017, there was that famous football game. Ohio State was playing undefeated Wisconsin.
That's right.
I really wanted to meet with you because I wanted to understand how someone could have knee surgery and 1 week later play as quarterback. And so, that I had missed that part of my medical education. But it actually, the way you explained it was brilliant, that he really had this sort of anesthesia for the first 2 or 3 days while he was vigorously working his leg, and it wasn't major surgery. So but then we talked about this idea of developing this independent organization that wouldn't create standards, but actually would be there to fill this huge gap, not just at the NCAA level, but in our society. Let's be frank, in our society, to help any association or governing body or high school or college to really understand what the standards are, and to have in place a system where they can evaluate how effective the school is or the conference, and they can provide expert guidance and really can sort of handhold in many ways to bring the school along. So that really was the development of the U.S. Council for Athletes Health. So I was in favor of that from the get-go. Actually encouraged you very much to move forward with that. And sometimes we had our bumps and bruises when it seemed like we were, kind of in the same space. And then, we actually developed what exists today, incredible boundaries. AHCA is this expert organization for independently assessing standards. And the NCAA Sports Science Institute is responsible, working with CSMAS, for developing the standards. And so it really, in my mind, was a perfect marriage. It was complementary, synchronous, if you will. And again, may sound self-serving, but it's not, for those who know me, since I've been pushing this for many years, even when I was full-time with the NCAA. I just think that's the ideal solution right now.
Yeah, it's so many places people work with a trusted partner or with other, some organization to make certain that they're meeting these standards. And I think that, as you know, that's our goal here, is to be collaborative, to be assistive, and to provide a wide range of solutions that can help when help's needed, and certainly to help make certain that institutions and others, organizations, are on track. I think that the final thing, just comment today, Brian, is to talk about how important this is for just the future of sport in general. I mean, I know that we don't want to get too outside the boundary here, but the reality is that although there is a lot of noise in sport right now, there's a lot of noise around a lot of things. Compensation is certainly one of them, and the ability for one to, to collect, money from their name, image, and likeness. And that's even filtering into high school sports and certainly into other areas of sport. And then there's, revenue sharing, and there's all of these things. But the future of sport, in many ways, if you look at youth sport all the way up through elite sport, really focuses on the ability for someone to be physically, mentally, emotionally well, to perform well, and to be able to do so in environments that foster their development. And so beyond this, the future of sport itself, doesn't it in some way become intertwined with this whole idea of providing this framework of health and safety?
Yeah, absolutely. When we look at sport, it really is about human development. And one of the most interesting chapters that I was involved with is in a book called Sports Neurology. And the first chapter is the evolutionary basis of sport. Sport actually is a recreation of society. It's a recreation of Homo sapiens. It's a recreation of humanity. And for sport to really be effective, it means that you are helping someone develop however they choose to. But ultimately, it's always about development physically, emotionally, mentally, and spiritually. And that must be foundational in sports. So that's one part of it. The other is, and I'm going to go a little off topic here, but many of you know that I've been very involved in youth sport, and have actually helped or have single-handedly written what we call the American Development Model for certain sport organizations. The American Development Model means, it actually comes from the U.S. Olympic and Paralympic Committee. It means that at every stage of development, you are engaging in sport in a way that is developmentally appropriate. developmentally appropriate physically, mentally, socially, cognitively, and spiritually. And so there needs to be some sort of overseer of that. And certainly the way we have been in the United States and the way we're moving now, even more so, there's sort of this great decentralization, if you will. So again, I think, look, I would like to believe that everyone in sport has the best interest of the athlete in mind. But when money gets involved, and we're talking big money now with NIL and with operatives and so forth, sometimes that can overpower the willingness for good. And so again, I think having the checks and balances and having some sort of independent agency that can just help us always remember the real value of sport. It's human development, and that must be done in a way that is healthy and that is safe for everyone, especially the athletes, but really everyone involved. So again, I get a little emotional when I talk about this, because I think the potential for sport is just so spectacular. But in our country, we're not getting it right. I mean, geez, 75% of kids, when they reach the age of puberty, they drop out of sport. We have a coaching situation where coaches are not empowered and they aren't even educated to be doing what they're doing. And then we have no real enforcement arm other than the legal system, the brutal legal system. And we don't have sort of an aid to say, hey, this is the best way to do it. So look, I I love sports so much. It gave me my life. It gave me a pathway of moving from, kind of a tough part of Detroit to being able to explore other parts of the world. And so I forever want to give back to sport. And again, well, it's why I'm happy I'm here right now. The NCAA gave me something that was unimaginably good. It really was, it was a gift. And but when we are handed a gift, it's also it's not just a privilege, but it becomes a responsibility to do something with that. And that's where I feel I am with USCA right now as well, just to continue this journey.
Well, Brian, thank you so much for the thoughts today. I think if anything, we've been able to spend the last 60 minutes or so certainly thinking about a lot in sport, certainly a lot of ways that we can think about how people can think about making certain that they set up the best framework, the best foundation so that athletes can perform their best. And look forward to future conversations, obviously. And thanks for all your insight today.
Yeah, well, thank you, Jim. Really, really good being with you again.
Good being with you. Thanks.